Hello everyone, this is Dr. Garima Sachdeva and today we'll be discussing about management of cervical cancer during pregnancy. We will be discussing about the important talk articles on the same topic, and at the end we will discuss some EMQ questions related to this topic. So stay tuned, hope you find it helpful.
Now, if cervical cancer is detected in pregnancy, how do you diagnose, stage and treat? So stage-wise diagnosis will be the same thing. You do cone biopsy or pap smear. After that you do a biopsy, all that. And treatment is different in pregnancy. So stage 1A1 without lymphovascular space invasion, then you do cone biopsy, and you do not do cone biopsy in first or third trimester. You usually do it between 14 and 20 weeks.
Okay.
And then these patients after cone biopsy can go for vaginal delivery.
Okay.
Okay. 1A1 with lymphovascular space invasion or 1A2 or 1B1. So in these cases, you have to do simple trachelectomy. Simple trachelectomy is you only remove the cervix. Radical trachelectomy is where you remove the cervix, parametrium, and upper part of the vagina also.
Okay.
Okay. So here you are doing simple trachelectomy. You only remove the cervix. So if the patient has the cervix has been removed, you cannot go for normal delivery now. You have to do LSTS only. Okay. Or the option is you do delayed treatment after delivery, or you give neoadjuvant chemotherapy.
Okay.
Stage 1B1, 1B2, you have to do radical hysterectomy and bilateral salpingectomy with or without bilateral oophorectomy with pelvic lymphadenectomy. So you have to do the complete surgery here. Okay. More than 22 weeks. If the patient is more than 22 weeks, you can delay the treatment. Okay. And give neoadjuvant chemotherapy for the time being.
Okay.
Okay. So this is how it is briefly. More than 22 weeks, all patients you remember, you can at whatever stage, 1A up to 1B3 only you can do conservative management. Okay.
Okay.
So in all stages, you can do delayed treatment after delivery or neoadjuvant chemotherapy.
Okay.
If it is less than 22 weeks and the stage is 1A to 1B1, then you do pelvic lymph node dissection. If it is positive, then you have to terminate the pregnancy. You cannot go ahead because it is already stage 3, with pelvic lymph node positive. If it is negative, then you can either do this delayed treatment after delivery or simple trachelectomy.
Okay.
Okay. Then less than 22 weeks, again, if it is positive, you have to do lymph nodes are positive, you have to do termination of pregnancy. If lymph nodes are negative, then you have to do either give chemotherapy or delayed treatment after delivery.
Okay.
Okay. 1B3 again, you either do termination stage 1B3 less than 22 weeks, you have both the option, neoadjuvant chemotherapy or termination of pregnancy.
Okay.
Okay. So these are the options. I'll come to the question one by one. First you read the question, then I'll come back to the options. Let me know when you have read.
Yeah. Options.
Yeah.
No further treatment.
Yes, it is no further treatment required.
Because
Because
margins
it is
are
less
there.
than 2 mm, no? It is stage, what stage is it? What stage is it?
It's stages.
What stage is this? Less than 2 mm with clear margins. I go back to the staging. Yeah. Now tell me what stage is it?
1A1.
Yes, it is 1A1. So 1A1 I told you, if everything margins are clear, no further treatment is required.
Okay.
Okay. So this is how only you will be getting the questions. Next question.
Mm.
First tell me what stage is it?
3.9 centimeter. So it is between 2 to 4. Stage 2B.
No, no. It is 1B2.
1B2.
Yeah, it is 1B2. I'll show you again. So it is here. 2B is parametrum involvement. If it is limited to cervix, it is always stage 1.
Okay, it was 3.9, right? So almost 4. 4 means it will come under, it is I1B2, right?
Yes, it is 1B2. Now, what is the treatment?
Cone biopsy.
Colposcopy, examination, biopsy. In 1B2, what will you do? Cone biopsy, what stage do you do?
I'm confused, ma'am.
Okay, I'll go back to what I taught you. 1B2, what do you do in young patients? It is in front of you.
Yeah, I'm just reading. Okay, so when it is less than 4 centimeter, so when do we do cone biopsy?
Only in early stages, 1A1.
Okay.
Okay.
Okay, this contains cancerous cells.
1A2, either cone biopsy or you do radical trachelectomy.
Okay.
P1, radical trachelectomy.
Okay.
If wants conservation. Otherwise, you do hysterectomy. One, if completed family, then modified radical hysterectomy with pelvic lymph node removal. 1B1, radical hysterectomy with pelvic lymph node removal.
Okay.
Then after 1B2 to 4A, chemoradiotherapy. If
Mm.
that not, if the patient is young,
Mm.
because chemoradiotherapy will cause hair loss and all that, no?
Okay.
Can give an option if it is less than 4 centimeter radical hysterectomy with pelvic lymph node dissection.
Okay.
Okay. So what is the answer now? What is the answer here? Answer.
Trachelectomy.
Trachelectomy. What stage was it?
3.9 to, I'm confused.
Abhi to you told no 3.9 what stage?
It is
3.9 centimeter. What stage?
second stage.
Sec limited to cervix always stage 1. Second stage is beyond cervix, either upper third of the vagina or parametrium involvement.
So less than 4 centimeter is
1B2.
how it is limited to stage 1? It is 3.9 means almost 4 or less than 4. Anyhow, it is 2A1.
No, if it is limited to cervix, it is stage 1. This
Okay.
is upper two-third of the vagina involved.
When it is limited to cervix. Oh, okay. So it is stage 1A2. Less than, okay, between 3 to 5. Then when it is second stage,
MM.
third of vagina is involved. Okay, when it is limited to cervix, when it is lesser than 5 mm, it is 1A2. Okay.
That was 3.9 centimeter.
Yeah, so it comes under stage 1A2.
3.9 centimeter, not millimeter.
9 millimeter.
Millimeter. 1A is micro invasive. It is easy. See, limited to cervix is stage 1. 1A is microscopic. So it will be in MMs.
Okay,
1B is
1A1 is less than 3.
huh.
1A2 is 3 to 5.
Yeah.
It is confined only to cervix.
Cervix. Yes.
Mm.
Okay. And 1B1 is
Mm.
macroscopic. If it is less than 2 centimeter, 1B1, 2 to 4 centimeter, 1B2, more than 4 centimeter, 1B3.
Okay,
Okay,
fine.
so what stage in the question? 3.9
That is
centimeter.
1A2 centimeter.
9 centimeter.
Oh,
Uh-huh.
3.9 centimeter. Then
Uh-huh.
it is 1B3. 3,
3.
1B2.
So 1B2, what is the treatment now? 1B2, what is the treatment in young patient?
Chemoradiation.
In young patient, chemoradiation anyways is not was not in the option, was it? It was 25-year-old, no? The patient is 25-year-old. Patient is 20. In young patient, what you will not, I told you, no, young patients you generally do not do
Yeah.
chemoradiation because rather you can do radical hysterectomy, pelvic lymph node dissection.
Okay.
So it'll
I'll
be,
memorize all this.
yeah, so now what option?
Where is hysterectomy? Last option, radical surgery with lymph node dissection.
Then next question.
What is
First
on
tell the stage.
Okay, trying on 4.5 centimeter. So when it is above 4 centimeter, it is stage 3.
3? What 3?
2B.
2 is outside cervix, no limited to cervix. It is just cervix, no?
This is only cervix.
They've not written, no, it is.
Okay. So 2 to 5.
If this was 1B2, then what is this? More than 4 centimeter.
1B3.
Yeah, it is 1B3. So now what is the treatment? She's
Same
30.
treatment.
Yeah. So she's not very young, so you can give radio chemo also.
Mhm.
Okay.
Okay.
37 years, no?
Mhm.
Okay. Next question.
For stage 1A2 cancer, she can go undergo normal delivery itself.
Yeah. After conization, normal delivery. Next question.
After 12 months,
Huh? It is 6 months. Practice at least for 6 months before getting pregnant. Next question.
prevention of preterm. What do we do?
Hmm? Okay, this also I'm not told. It will be in the further slide. You have to do serial monitoring
Hmm.
for the ischemic length because you have removed the cervix, no? So there are chances of preterm delivery. So you give them vaginal progesterone and serially monitor the ischemic length.
Mm-hmm.
Okay. Then
Okay.
after radical trachelectomy, what will be the mode of delivery? After trachelectomy, mode of delivery.
After radical trachelectomy.
Hmm. There are only two modes: vaginal delivery or cesarean.
without, without cervix and she can deliver normally, no?
No, she cannot because she doesn't have cervix. No, how will you deliver? How will you monitor the progress?
And like without the cervix, how will it be? It will be stenosed.
Yeah, it will be stenosed. They put
Okay.
sutures, no, so you cannot. While they remove the cervix, they put sutures. So, so what is the mode of delivery?
Cesarean only.
Cesarean at 37 week. Okay. Okay. So this is another talk.
And why are we taking at 37 itself?
Hmm?
Why are we taking at 37 itself?
Because
37.
anyways, they are at risk of this. No. Otherwise, sometimes what happens? The baby grows big,
Mm.
so there can be trauma.
Okay.
Don't want spontaneous labor, basically.
Okay.
So that's why 37. So these are the recommendation of antenatal care who have undergone trachelectomy. This was another talk. So these should be managed with consultant-led obstetric care with multidisciplinary input. You have to give these patients vaginal progesterone from 12 weeks until 36 weeks. Serial fortnightly. So every 14th day you have to do an ischemic scans. Urine should be tested for culture and sensitivity and vaginal cultures for bacterial vaginosis at first obstetric visit. And additionally, you can give prophylactic antibiotics if clearly clinically indicated between 16 and at 24 weeks. Then you give prophylactic because you're delivering them, you're doing cesarean before 39 weeks, so you give prophylactic steroids. Okay.
Okay.
Consider avoiding sexual intercourse from 20 weeks onwards as this may be a source of infection,
Mm.
and aim for elective delivery around 37 weeks. So these are important
And
points.
after this radical or simple trachelectomy?
Radical trachelectomy. Any trachelectomy,
Okay.
anyway, you have removed
Okay.
the
How the vaginal suppository is kept?
vagina is there, no trachelectomy. They just remove the cervix, parametrium, and a part of
Okay, so
upper.
like the cervical part is removed.
Yeah, vagina is there, no. You can put it vagina there. Okay, understood.
Yes, ma'am.
Okay. Then this question, these two questions. This is another talk: pelvic accentration for recurrent gynecological cancer after radiotherapy. So question number one.
Mm.
Uh, tell the answer.
Okay, so MRI. Mm.
Yeah. So it is MRI. Oh, it is MRI. So if you have to see recurrence, you do MRI. Okay.
Okay.
If you have to see
Mm.
distant meds,
Mm.
okay,
P.
then you do
Mm.
PET CT.
Okay.
Okay. So for pelvic accentration is where you remove a large part of uterus, bladder, bowel. So you will
Mm.
be if there is no distant meds. Otherwise,
Okay.
it's not useful. So for
Mm.
distant meds, you do PET CT. For
Okay.
local spread, you do MRI.
Okay. Mm.
Okay, only this much was important from this talk. So this was all about it. Any questions?
And,